And when it comes to genetics, so we know the 23 pairs of chromosome is the standard genetic number. Anything gained or loss will result into genetic abnormalities. Okay, especially women with advanced maternal age, they will have this genetic abnormality naturally in their oocyte. Okay, so in our IVF, when we have a couples who are 38 plus, we suggest them to go for a donor oocyte in case they don't want to have a multiple try, because their egg, we know that there will be a lot of genetic abnormalities. Or in case if they want to go for a self oocyte, yes, we give them a chance, because it is our responsibility to tell them which is the right way for them. Because what happens when it comes to a practical day-to-day life activities for an embryologist, patients will ask us that why didn't you tell us that because in advanced maternal age, the quality will be low. We could have gone for a donor embryos. Some people, they say that even if it is advanced maternal age, we want our own chemist, let us go with one. So it is our responsibility to tell them what are the pros and cons with respect to the advanced maternal age. And then decision is, it's their decision. Okay. So, but generally remember, when there's an advanced maternal age, the egg quality will go down. That is, the genetic content of the egg quality is like very less. The aneuploidy rate is very high. Okay. Now, to find out all this thing, so now we came to know how a sperm plays important role in the genetic, and how oocyte plays important roles in the genetic. How do we choose the egg and the sperm for your IVF procedure? So now it's all done. As an embryologist, you will avoid all this disturbance, that is poor morphology, poor oocyte, the morphology, everything. So you make sure that you take an ideal oocyte, you take an ideal sperm, you inject and create an embryo. But again, this doesn't mean that they're genetically stable. You are avoided the high chance of getting genetically unstable embryo by avoiding all this parameter which we discussed so far. But at the same time, it doesn't mean that if you take a very good sperm, morphologically good sperm, or a pixie or a max sperm, or the oocyte which are genetically good, it doesn't mean that it will always result into a genetically stable embryo. So now, to identify whether this is the final thing. In order to identify whether the embryos are really genetically stable or not, we have a embryo biopsy procedure. This again divided into two terminologies. One is PGS and PGD. Now we'll understand what is this PGS and PGD. So PGS stand for Preimplantation Genetic Testing or Screening, which we call it as in a short form, we call it as PGTA or PGS. Okay. The second thing is Preimplantation Genetic Diagnosis, that is PGTM or PGD. Now you understand this thing. There are two terminologies, screening and diagnosis. So PGS, which is Preimplantation Genetic Screening, PGD is Preimplantation Genetic Diagnosis. Okay, it has two different terminologies. Let us understand this. PGS, in a previous procedure, what we do is we will check whether the chromosomal numbers is normal or not, whether it has 23 pairs of chromosome or any numbers rearranged, now any extra number or a less number in the chromosome, which is either could be 24, 25 or 22 or 21 or 19, whatever. Okay, this test just says that the embryos are euploid or aneuploid. Euploid in the sense they're genetically having a good chromosomal distribution. Aneuploid or chromosomal distribution is not proper. Chromosomal numbers are not proper. This is the simple test and that's what it does, PGS. That will be called as screening. Now, PGD stands for diagnosis. Now, when we know that, okay, there is some abnormalities, now we have to find out how do we diagnose it? Now, okay, let me explain this. Now, in PGD, what we do is any particular disease, say for example, cystic fibrosis or hemophilia. When there is a hemophilic disorder patient, which we have to diagnose. Okay. Now, how do we identify this? when we counsel a patient for a genetic counseling, we'll take an history, whether if there is any first baby who's having any genetical Down syndrome or Klinefelter syndrome or this hemophilia disorders, all this thing, or cystic fibrosis, all this thing. We will see that whether first baby had any issue or in their previous generation, that is, the couple's father and mother had any genetical issue, or their father, that is, the couple's grandparents had any genetical abnormalities in the baby. So if any genetical abnormalities which is there in the previous generation, again previous to previous generation, that means the genetic disorder could be carried out in the forthcoming generation, or the disease can be carried out for this couple for the baby which they are having, that is the third generation. Now, how do we avoid this? Is again, they do a karyotyping, and in most of the karyotyping, it says that whether who's having, husband is having genetical issue or the wife is having the genetical issues. Now, we want to make sure that any of this existing genetical diseases should not pass to the fetus. So here in PGD, what we do is we target a particular gene and see what is that, whether disease. I'll make you, let me make a clear example for you. Say, for example, there is a defect in 19th chromosome, which can probably result into Down syndrome, I guess. Okay. So we know that in case if the embryos are formed in this particular patient, when the fetus is formed in this gamete of husband and wife, there is a high chance that at 19th chromosome, there might be some defect, though there is a 23 pair of chromosomes, which is normal, which in PGs it says normal. So this 19th chromosome will have certain defects, so that we do a PGD. So in PGD, we'll come to know that, okay, this particular 19th chromosome has some structural rearrangement, or there is an addition or deletion of chromosome here. So this 19th chromosome can result into this particular disorder. So in PGS report, when we do a PGS report, we'll come to know that, okay, this patient in particular 19th chromosome or 21st chromosome or maybe second chromosome, whatever, has certain defects in it. So with respect to that particular number of chromosome, if any defect, that associated defect is carried out into the fetus, what your report will tell us. That is, PGD report will tell us. So we will counsel the patient that, yes, in this particular 19th chromosome, if there is a defect, so there is a high chance that the fetus can have a Down syndrome. So we will avoid transferring that particular embryo. So in this way, 99% we are very sure that we have chosen embryo which are genetically stable, and the accuracy is 99% in an embryo biopsy procedure. But again, in embryo biopsy procedure, there are different technology. The present latest technology which we use to analyze the quality of DNA is NGS. Okay? NGS is NGS is called as the next generation sequencing. Before you had fluorescent assay, all this. These are outdated technology. NGS is the latest technology which will make sure that, and accuracy is 99%. Almost it is 100%, but still they not claim as 100%. It is 99% accuracy that it will say that whether these embryos are genetically stable or not. Okay, so this all the syndromes. The Down syndrome comes on the 21st chromosome. Okay? So these are all the syndromes which is there that can be identified by PGD procedure. Hemophilia, thalassemia, Fragile X syndrome, sickle cell anemia, many syndromes. Now, how do we do so now we came to know how we select the oocyte, how we select the sperm, and how do we manually make sure that we select the sperm, we select the gametes where the genetical abnormalities can be avoided. That is by making sure that you select this, you differentiate the embryos with respect to two polar body and two pronucleus. And you know what are the techniques which is involved. That is the embryo biopsy techniques. Now, here we will be learning what are the different types of techniques which is there, and different types in biopsy procedure. One is the oocyte polar body biopsy. So here, when we do a polar body biopsy of a oocyte, this polar body will mimic the DNA content of the oocyte because this is part of the oocyte. Okay. So when we analyze the oocyte genetically, that is by doing the biopsy, this will say that whatever the chromosomal numbers, which is euploid here, euploid or aneuploid, the result will say this particular oocyte is a euploid or aneuploid oocyte. So in this way, there is a particular procedure where we can detect whether the oocyte is having a euploidy or aneuploid. Okay. Now coming to the zygote. Now after fusion of, see the chromosomal error can happen at any part of or any incident of the embryo development. That is either on the oocyte or fertilization or fertilized zygote or a cleavage stage embryo, you may have certain genetical abnormalities, or even in the blastocyst stage, you may have certain abnormalities. So you never know where the abnormalities can occur. So now here there's one more previous technology which we were using is, okay, now oocyte, this will say only the oocyte is good or not, genetically stable or not. But this is a little improved procedure where after the fusion of sperm, the polar body which is formed, right? So this polar body is tested for genetical abnormalities. You can't take the pronucleus. You know why? Because you're taking a part of gene in it, either the oocyte gene or the sperm gene. So when there is no gene, this has only 23 pairs of chromosomes, right? This is an haploid embryo, haploid zygote will become. No? Haploid zygote is an abnormal, right? But this polar body is the indicator of what is there inside, right? So this we will take and subject that for a what you call it as embryo biopsy. But again, the drawback here is we don't know whether the polar body which we are taking is of oocyte or after the fusion of sperm, again the second polar body comes, right? So whether that. So again, this is not a very accurate procedure whether we can justify that yes, these are genetically stable. Now again, this two method is completely outdated, so we never go for this. Then they started doing the embryo biopsy. That means after fusion of sperm and the oocyte, not the zygote. Now let us consider the embryo which are divided. So here on the third picture, this one cell are divided into multiple. See, on a day 3, you have 6 to 8 blastomeres, right? Now, this particular blastoma, say 1 or 2 blastomeres is taken and then subjected for embryo biopsy. So this was maybe down the line, maybe 6-7 years. So this is what we were following. But what is the major problem here is there is a different dimension of embryology. That is nothing but embryo mechanism, embryo repair mechanism. Okay. Though embryos, say for example, in zygote stage or during the embryonic cleavage stage, if there is any genetical abnormalities, embryos can repair itself. Okay, which can happen after this procedure, after the day 3. Okay, when from day 3 to day 5 conversion, any genetical error which is happening in a cell division, if it is a minor correction, embryos can repair itself, right? But that process will take certain time, so that will be completed on day 5. So day 3, there might be an intermediate stage of self correction, or they wouldn't have been started yet. But in case if we take that embryo and subject for biopsy, it may say that it is an aneuploid embryo. But this aneuploid embryo, there's a high chance that it can go for a self-correction, turn into an euploid embryo when it comes to a blastocyst. So now again, this type of day 3 blastoma biopsies, again, it is an outdated technology. Not much people use this. Now the present technology is the right stage of embryo biopsies is your day 5 biopsy. That is the blastocyst biopsy, where the self-correction would have happened to a certain extent. Okay. So we take here we take out the differentiated propactoderm cell, and this cells, when we take out, usually it comes with like 5 to 6, 10, 6 to 5 to 10 cells in one go. So this again will have more number of DNA. That means more number of DNA, it will be better chance of most accurate prediction in the genetic lab. Okay, so this is the present technique which we follow. That is the day 5 embryo biopsy, where we can make sure that there is no the embryos would have completely gone for a self-correction, and that is this day 5 embryo biopsy result into high accurate result, so that they can claim for 99% accuracy. Okay. This we discussed. I'll just skip this. Okay, so this is again some genetical disorder where trisomy, in case you can see 21st chromosome variant defect. So this is all the example of PGD diagnosis. Okay, so Down syndrome, 21st pair of chromosome, there is a issue. Edwards syndrome, on 18th chromosome, there is an issue. And 13th chromosome, you have Patu syndrome. So like this, you have different syndrome. And triploidy, where you can see each chromosome, you should have a diploid chromosome, right? So sometimes there'll be an extra additional chromosome which is added that will turn into triploidy. You can ask me like when this situation will occur. This is very common when you put a sperm and oocyte for a conventional IVF. That is, remember I told you, right, when you check for a fertilization, you have to make sure that true polar body and true pronucleus. That means when you put when you subject the egg and the sperm for a natural selection, if your sperm concentration is very high, what happens? Multiple sperm can enter inside the oocyte. Generally, the nature is one egg and one sperm, right? Because of the concentration is very high, so multiple sperm will enter into the oocyte, which will result into triploidy or even tetraploidy. Generally, the standard is 1 lakh sperm per oocyte should be your sperm concentration, which you are supposed to inseminate for one oocyte. There is a different calculation for it when it comes to IVF insemination. Okay, it's not just randomly you take a sperm and inseminate into the droplet where you have multiple oocyte. Either they will not fertilize, either they will fertilize with more number of sperm, which can result into triploid or tetraploid. Okay. Okay. This is again, okay, not much. Okay. Now let us see this thing here. Sorry. Okay. There is one more mechanism called mosaicism. What is mosaicism is, you can see here, a particular embryo will either give a false positive or a false negative result because of abnormal distribution of the chromosome. Here, some part of the chromosomes will be, some part of the cell will be having an abnormal chromosome, and some part will be having a good chromosome. Okay, if you see here, this is a day 3 embryo where the red one are abnormal, the green one are the normal cells, abnormal blastoma and the normal blastoma. So what happened is when this green cell will when they divide, so there are different possibilities. Either they may turn, because they may go for a cell correction and they may turn into a normal blastomer, or the abnormal blastomer which was here may go for a self correction and turn into a normal blastomer, or some abnormal blastomer can go for apoptosis and they'll die, and some will arrest itself. Now, when they turn into a blastocyst, you have either the red cells which you are seeing in a blastocyst are abnormal. The green one which you are seeing is a normal blastocyst. Okay, I'll tell you what are the false positive, false negative. Now, when you do an embryo biopsy, so what we do is we say, for example, when you see a live cell, see here it's a day 3 embryo. When you're seeing a day 3 embryo, you never know which is the abnormal euploid blastoma and an aneuploid blastoma, because all will look similar. So here it is color differentiated. You know which part is abnormal and which part is normal. When you do a random biopsy procedure, we randomly take out any cells here. Say, for example, if I inject my biopsy needle in this particular position at 3 and 4 and 5 o'clock, if I take this cell, though the ICM be euploid, the test result will say aneuploid, which will result a false result. Okay, though it is a good. In case there is one more group of embryo, let us see this. See, there is one more. See, these are all the different possibilities. Either the day 5 where ICM could be euploid and the tropactodome could be euploid, or it could be completely euploid where ICM is also euploid, tropactodome also euploid, or there is one more possibility where part of tropactodome will be euploid and some aneuploid, and some the ICM will be aneuploid. Now, if I take randomly this euploid cell here and set it for a biopsy, it says yes, this embryos are completely genetically stable, which you can consider for the transfer. Because of mosaicism, the ICM is abnormal. So the test says that the part which you are given for the testing says that it is genetically stable. That is aneuploid. You can consider this embryo for the transfer. But actually, the ICM is aneuploid because of mosaicism. Or there might be one more possibilities where diploid, aneuploid mosaicism, where ICM part of the ICM will be euploid and haploid, and then part of the tropactoderm will be haploid and euploid and aneuploid. Or the false negative here, you can see the tropactoderm is completely normal. Wherever you do the biopsy, it says that it is a normal embryo, but the ICM will be abnormal. Or here, the part which you take here, this embryos may say that this is an aneuploid embryo, because the part which you are given is an aneuploid, but actually it will be a euploid embryo. It can result to false positive because the ICM it's an euploid. So that's the reason the NGS says that it is 99% accuracy, that 1% is because of this mosaicism. They can't predict that what it is, whether you're given a euploid part or an aneuploid part. Okay. Okay. So yeah, this is a day 3 biopsy. Again, you can see from here, we just make a small hole here and we inject the biopsy pipette. We pull out the cell and the pulled out cell is separated completely. And this particular cells is given for the genetic lab for embryo procedure, biopsy procedure. Okay. And then again, cons and pros and cons here is if it is a day 3 biopsy, I told you, genetical changes wouldn't have, genetical error wouldn't have rectified completely. So generally we go for a day 5 biopsy. Day 5 biopsy, it provides more cell to analyze. It requires diagnose even the monogenic disorders, even the low degree of mosaicism, where when you do a polar day 5 biopsy, the mosaicism chance of getting error will be little lesser. But again, it depends upon the cohort of mosaicism which we have. Here, the ICM plays a very important role, which is the actually ICM is the one which actually does the